Okay, George, I'll do my best, so I will try to escape some slides. It's really a pity that I cannot be there because we have another congress in another place now, right now in Athens, so I have to be there right after the presentation. I really enjoyed the case. So let's go to the bicuspid valve. Of course, we know that there are differences, significant differences between tricuspid and bicuspid valve in the asymmetrical leaflets. They increase the wall stress, so there is different formation of calcification on the leaflets, and of course sometimes we have to deal also with the dilatation of the ascending aorta. So we have to treat with different anatomic modalities. I just want to remember to remind to all the audience the difference, the severe classifications, type 1 and type 2, which are the most common one, and we can really appreciate it easily by the CT that we do in all patients. And just for running, there are also other classifications like the Gila-Howe classification systems that can provide us some more detailed information. I try to escape some of this, and the complications that are coming from the anatomy of the bicuspid valve, we have to treat with different implantation depth, and of course we have to treat with different prevention of the unfolding of the stent, and of course with the PVL that we have in the final autography. So there are some critical points for these patients, and we usually treat them in a younger age, so we don't have the perfect result that we should anticipate in all these patients. So we have to explore the impact of different multi-slice computer tomography algorithms regarding the depth and the and where's the point that we need the maximal radial strength of the valve, like the core valve here or other valves. And we know that there are differences also regarding the outcomes, although the majority of the trials have shown similar results to the tricuspid valve. So they are comparable along several studies. I just want to remind you the STS that all-cause mortality, stroke, and valve hemodynamics were not different at 30 days in the bicuspid valve and the tricuspid valve in a small number of patients, however, that we can see here. 1 year outcome in the JTVT registry, there was no difference in mortality and the MACE at 1 year. I just want to go to skip some slides. Similar outcomes in SAPIEN 3 valve as demonstrated in the match control cohort of patients with bicuspid versus tricuspid valve. And the primary results from the EVOLUTE low risk showed primary safety endpoint really good, 1.3% mortality. The primary results from the EVOLUTE in the bicuspid trial, as you may see here, according to the different types of valve, although the numbers are very low, show that the annular sizing achieved in 95% of the device success, low mortality, low stroke rate, low rates of PVL, and consistent hemodynamics across severe classification. Regarding the self-expanding valve, again, no differences compared to the tricuspid valve in 150 low-risk bicuspid study compared to 700 patients. And you can see with the tricuspid with the red one and the blue color with bicuspid, no essential differences statistically, although there was an increase of 0.7 to 2.1 in deaths and more need for hospitalization in patients with tricuspid valve, which was really surprising. The impact of pacemaker in these patients do not seem to have really an impact with implantation of pacemaker. They are not exposed to an increased risk of MACE at 2 years follow-up, although the 2 years follow-up in these patients is really not elucidating the long-term results. The low-risk transcatheter aortic valve replacement, again, you can see here in the bicuspid and in the tricuspid setting, mortality, disabling stroke, and coronary obstruction. There were no statistical differences. You can see that less than 0.5% of complication in these subgroups of patients. So if we can compare, this is a very nice paper published in JACC, Intervention, tricuspid versus bicuspid valve. You can see that the device success rate is similar, has similar frequency of the 1 year mortality. The peri-procedural complications have an increased frequency in the bicuspid anatomy, but not in a cohort with matched characteristics. So there is higher risk in bicuspid, especially with the self-expanding valves and the new generation devices. And there is an increased frequency in bicuspid valve anatomy with PVL from moderate to severe as classified in these studies. Moreover, regarding the cerebral ischemic events, there are increased occurrence in bicuspid valves, the incident rate 2.4 compared to 1.6% in the tricuspid valve. And finally, with the annulus rupture, there was increased occurrence in bicuspid valve anatomy, 0.3 versus 0.02%. It's very low, 0.3, but it's compared to 0.02% is increased. So these are the main spots that we can have in these patients. However, after these trials, you can see that the 30 days and the 6-month rates in the multicenter observant 2 study regarding the results of bicuspid valve, you can see that pre-dilatation was increased, although the ejection value was greater in these patients. They said that the bicuspid valve at the 6-month rate, there was a small increase regarding the stroke in these patients. So we come now in the final landmark study in which we also participated, and I think it's a very good study regarding the current status with the contemporary valves that we are using in this in the last years compared to the MyValve study, which is a balloon expandable valve. And the primary endpoint was not different between the contemporary valves and the MyValve study, and the MyValve valve, 24% compared to 27%. And you can see that also the pacemaker rate was similar between the two groups, 15% compared to 7.1% with the contemporary valves. And in the analysis that they have done, there was 7% rate of bicuspid valve. So TAVR for bicuspid valve was not different compared to the, we didn't have any difference between the self-expanding valves and the contemporary valves with the SAPIEN compared to the MyValve. So in 52 patients only, you can see that there were no differences regarding the strategy that we selected regarding the valve that we can use. So there was no difference in the primary endpoint, and the primary composite endpoint at 30 days was not statistically different between the two strategies. In the Notion also 2 study, the first comparison between surgical and SAP and TAV randomized in low risk patient with bicuspid valves, so that the intention to treat analysis, the 1 year occurrence of the primary endpoint was 10% in the TAV and 7% in the surgical group. However, this was not statistical difference with a p-value of 0.3. In the Notion also 2 study, in the bicuspid cohort, you can see that the TAV had more death, stroke, or hospitalization compared to the surgery with a 3.9%, and this difference was not observed in the tricuspid cohort. So there are some signs of more complications in this population. However, bicuspid valve is not always the same. I would like to share with you just 2 cases, and I finish my presentation, that you can have a very old patient, 87% with bicuspid valve, which is a different animal compared to what we see in the younger patients. And you can see that you can have, with a balloon expandable valve, a really good result after the implantation of a balloon expandable valve. 77-year-old female patient, bicuspid valve, you can see that there is a rough between right and left here cusps, intermediate surgical risk, and you may appreciate here the orthography before, really calcified. balloon predilatation, and you can see here that with a balloon that we try to stabilize it. As you may see here, you can see the waist above the annulus, and you can see now that we can implant the valve. Post-dilatation, I don't want to waste your time, and we can have an acceptable result. So even in younger patients with a bicuspid valve, you cannot have a perfect result, although it's acceptable, because of the different anatomies that you can have. So in conclusion, TAVR is in bicuspid poses challenges due to the complexity and the frequently associated aortopathy in these patients. The results have improved, however, they are not in all studies similar to the tricuspid valve, although we have low incidence of perivalvular leak. Associated aortopathy is less of a concern in older patients. However, in younger patients, there are concerns regarding the durability and the long terms in this pathology. Thank you for your attention.
Great. Maybe you can have a brief comment by Dr. Dardas while we are preparing Dr. Vamingas live in box.
Congratulations, Kostas. Your results are really exciting from the cases that you showed. Just one question. If you have a relatively young patient, let's say 70 years old, with a bicuspid, typical bicuspid type 1 valve, without aortopathy, in your preference, what would you prefer, a balloon expandable or a self-expandable valve? And why?
Difficult question, as always, from Petros. This is a difficult question. The first answer would be balloon expandable valve, due to several reasons that we can discuss for the younger patients. However, if the anatomy is really complex, I would also like to have a second and third chance for repositioning the valve also in this patient. So balloon expander would be my first choice, but I would like to see where is the outflow tract if there has calcium to avoid any rupture. Regarding the coronaries, also it's in favorable of balloon expandable valve. So my first choice would be balloon expandable valve. I would have to say.
Yeah, I agree with you.
What would you say about that?
Well, it's also very important the shape of the bicuspid valve, also flared, or it's very important to evaluate the supraannular view of the valve in bicuspid anatomy, flared or So balloon expandable valve will be first choice in different anatomy, and self-expandable valve will be the first choice into the two different anatomies. And this issue was discussed in Bavard registry, so there are also three important views according to the supraannular measurements.
Yeah. What do you say?
Yeah, I had actually the same. That's the million-dollar question. Do we prefer balloon expandable or self-expanding valves for bicuspids? And my experience so far has been that with bicuspids, I have probably better control of the implantation depth and height with the balloon expandable valves. And also, I have a less PVL in general because the way the balloon expandable valve conforms in the sometimes elliptical annulus or where the commissures of the bicuspid valves are. So I've seen, although there's no strong data to suggest it, I've seen that I have better control of the implantation depth and probably less PVL with the balloon expandable, not to mention also the coronary access and the future lifetime management of the AS patient.
Yeah, before we're moving, Kostas, thank you for a beautiful lecture. I just want last comment. I totally agree. I think that, first of all, a young patient that you anticipate and so on, and you need a TAVR in TAVR, and you need a coronary access, probably in this case, the balloon expandable will be more suitable. But just one issue regarding the calcium. always I hear it again and again, that a patient that is heavily calcified, yeah, we should take a self-expandable and not a balloon expandable. Look, guys, I'm saying it like a broken record. We don't compromise anymore. So if you put a self-expandable and there is a PVL, you do post-dilatation. So practically, you did a balloon expandable valve. And if it's too dangerous and it's a 70-year-old patient and you are afraid of doing post-dilatation, then the patient should go to surgery and not to TAVR. So whatever you look at it, the decision-making should be built around so many issues together, and not just whether the implantation is easier, etc., etc. And I'm saying it again, and you know that I'm TAVR addict, but surgery is not a curse. Definitely not for a 70-year-old patient with a bicuspid aortic valve. Thank you.
Yeah, definitely. I think this is a very, very good closing comment. This is a great session, and let's look into the TAVR bicuspid valve from Thorax Center, live in box. Let's keep the panel via the internet. Whoever likes to continue staying in the session, running a little bit late,